imagine the fine line a surgeon has to tread. If the micro motion is less than 50 micrometers, that implant will stabilize. If you have more than 100 micrometers, that implant will not heal, it will not osseointegrate, and it will be fibrous union, and the patient will continue to have thigh pain. That's why the surgical technique has to be meticulous. Cementless technology allows us to control leg lengths. We also do that by using these offset femoral stems. To give you an example, both these femur stems are of the same size, but here the neck is long and over here the neck is wide. So for the same stem we have longer necks and wider offsets. That allows us to control the limb length discrepancy, and that also allows to control dislocation, which is why now the incidence of dislocation has gone down to 2 to 3% after a total hip replacement. Other advances in metallurgy include porous metal alloys. Now tantalum has become very popular. It allows bone to grow into the implant much more better than what you saw with porous coatings. And problem is that just a single cup costs $5,000 US. So I've used it for difficult revision cases or difficult primaries, but obviously cost becomes a big issue. Alternative bearing surfaces have been introduced now. People, not now, now is a wrong word. Few years ago people were talking about metal on metal hip replacements. This is the bearing surface. So this is your polyethylene liner, this is the metal head. So this is a metal on polyethylene bearing surface. Metal on metal was something we orthopedic surgeons flirted with in the 1970s. And at that time the results were good, but because of bad long-term results, it was abandoned. The thought process at that time was perhaps that metal technology has improved today. We went back into this. Orthopedic surgeons sometimes like to revisit history, but it came back at us, and it has shown that now there are issues with pseudotumors and metal ion sensitivities. That's why big academic centers in the West are moving away from metal on metal, and for the same reason they are also moving away from surface replacements. Then ceramic on ceramic was also introduced, and this is done mainly in patients, especially female patients who have metal allergies like nickel and gold, and in them this can be a better option. But ceramic hips are known as squeaking hips because whenever the patient sits or stands, the implant squeaks, and that can sometimes be socially embarrassing. If you look at the outcomes in cementless, the outcomes are relatively better as compared to cemented. But from the acetabulum point of view, the cemented does worse. That's why we've come to a concept of hybrid. So we like to use cementless acetabulum and cemented stems. Complications are similar to the knee, except limb length inequality and periprosthetic fractures may occur a little more over here. We've also learned a lot about thromboembolic prophylaxis. It has changed over the years. First, the thought was that Asians don't need it, but now there is data coming out from Singapore, from India, and even at our own AKU data has shown that no, we do need to anticoagulate patients, and it is a little more in knees as compared to hips, but the fatal PE is slightly more in knees as compared to hips. We've also started using the oral agents, but cost is a big issue even in this part of the world. Rehabilitation cannot be overemphasized. This is very important because our job finishes in the 1.5 hours that it takes to replace the hip or knee. Thereafter, the more the patient works with the physiotherapist, the better is the outcome. And in the acute phase, what data has shown from the West, that if the patient preoperatively meets the physiotherapist, they tend to do better post-operatively. And in the acute phase, once they are in inpatient, things like biofeedback also help to get the patient's motivation to continue to do physiotherapy, because physiotherapy, they don't see the immediate different exercises have to be done to get rid of the iliopsoas contractures. If there was an abductor lurch because of the short abductors, they all have to be dealt with post-operatively as long as the releases have been done intraoperatively. And then gradually you go on to start developing